So shock can be defined as a state of cellular and tissue hypoxia due to reduced oxygen delivery and or increased oxygen consumption or inadequate oxygen utilization. This most commonly occurs when there is circulatory failure manifested as hypotension, such as reduced tissue perfusion. Although shock initially is reversible, prolonged shock eventually leads to irreversible tissue injury. So in shock, you're going to have a state of the body in which the blood can no longer carry enough of the oxygen to provide for the cells, thereby leading to cellular hypoxia. And we know that hypoxia is one of the forms of cell injury to a cell. And once we have cellular injury, we can have cell death if there's no adaptation. So generally, a shock would result from a circulatory failure on the part of the body to adequately provide for its oxygen demand and its nutritional requirements in line with carrying out a particular function of that cell. So we know that shock can be also graded into four stages, of which the final, dependent on the amount of blood loss, if it's hemorrhagic shock that is associated with, and at some point the shock becomes irreversible and cannot be treated with any ionotropes or fluid resuscitation. So the types of shock are hypovolemic, septic, cardiogenic, anaphylactic, and neurogenic. Classifications of shock. Physiological classifications better describe underlying problems. So we have cardiogenic shock, hypovolemic shock, and distributive shock. The distributive shocks can be neurogenic shock, septic shock, or anaphylactic shock. So in cardiogenic shock, this is where you have the shock arising from a cardiac insult, resulting in the inability for the circulatory system to adequately perfuse the cells. In hypovolemic shock, it's mainly due to derangement in the fluids in the body. Usually it's because of loss of the fluid compartments in the body, the loss of volume in the vascular compartments of the body, resulting in a drop in the BP and inability to actually support the cells. Then we have the distributive form of shock, which is also usually as a result of hypotension, but you find that the volume of the intravascular volume is still maintained. So in here we have a vehicle that has been involved in an accident. What is the most likely form of shock you're going to see here? Most likely you'd see hemorrhagic shock because of injury and injury to the driver, the passengers, and any pedestrians that might have been involved in this accident. So hypovolemic shock. Hypovolemic shock results from low cardiac output due to loss of blood or plasma volume, for example, due to hemorrhage or fluid loss from severe burns. Hypovolemic shock can be also classified into non-hemorrhagic and hemorrhagic shock. The non-hemorrhagic shock includes vomiting, diarrhea, bowel obstruction, pancreatitis, burns, neglect, or environmental, such as dehydration. And the hemorrhagic shock include GI bleed, trauma, massive hemoptysis, abdominal aorta aneurysm rupture, ectopic pregnancy, postpartum bleeding as well. So what is the pathophysiology of shock? So in the pathophysiology of shock, you have to realize that generally the shock is coming about because of loss of volume of the intravascular compartment, which causes a circulatory collapse, thereby impairing the ability of the circulatory system to supply the body and adequately perfuse the cells. So you have an initial decrease in intravascular volume due to some sort of loss, such as bleeding or even vomiting or diarrhea. So this results in a drop in the cardiac output. And because of this cardiac output, you have a number of homeostatic counter-regulatory mechanisms being activated, and this results in a shift of the interstitial fluid as well as activation of aldosterone and ADH, antidiuretic hormone, which are hormones that tend to favor fluid retention rather than fluid loss. You'll also have splenic discharge. And all of these are in order to try and increase the intravascular volume. You'll also have catecholamine release. So you have your norepinephrine, your epinephrine, your endogenous catecholamines, resulting in an increase in systemic vascular resistance and an increase in the heart rate. This combined effect results in an increase in cardiac output, and as a result, you have more volume loss, especially if the initial cause of the intravascular depletion is not corrected, such as a hemorrhage. So at this point in time, you'd want to consider, if it's hemorrhagic shock, you'd want to consider surgical interventions such as suturing. In a GI bleed, you'd be talking about things like banding if it's a variceal bleed, or you'll be talking about spraying of an epinephrine or injection of epinephrine at the site of the bleed, in addition to other hemostatic interventions. So, because you're having more volume loss, you eventually it eventually results in an increased in cardiac out a drop in the cardiac output, and this also results in reduced systemic pulmonic pressures. Therefore, you have reduced tissue perfusion, and it's actually a vicious cycle. Because of the drop in the cardiac output and the drop in the tissue perfusion, you can have further drop in cardiac output because there's not enough tissue perfusion to supply the heart, which is the actual organ responsible for cardiac output. And eventually, you have impaired cellular metabolism. The second form of shock is called septic shock. So in this form of shock, it's usually a shock that arises from the host's or the host's immune response to a particular foreign body or foreign antigen. So septic shock results from arterial vasodilatation and venous blood pooling that arises from the systemic immune response to microbial infection. So Bone and All in 1992 were able to summarize the causes of septic shock, especially, and they created this very famous Venn diagram which shows the contribution of each infection towards sepsis and septic shock. So we have this interlink between infection, systemic inflammatory response syndrome, and sepsis. So the infections listed are bacteremia, fungemia, parasitemia, viremia, and others in that descending order, which intersect with sepsis. But we should know that there's also systemic inflammatory response syndrome, which does not require an infection to set in. So in this form of response syndrome, you have pancreatitis, burns, trauma, and other non-infectious stimuli causing or non-infectious agents causing this SIRS. So causes of septic shock include overwhelming microbial infection, endotoxic shock, gram-positive septicemia, fungal sepsis, and superantigens. For example, those seen in toxic shock syndrome. This is usually due to infection with Staphylococcus aureus species. So pathogenesis of shock, generally the pathogenesis of septic shock or sepsis in general is not clearly understood, but it's believed to be an interplay between the inflammatory system, the source of the insult, which could be an infectious agent such as a bacteria, or a virus. In this case, we'll call it an organism. So what usually happens is this organism induces a systemic inflammatory response, and as a result, you have diffuse endothelial disruption and microcirculation defects. So you'll find the endothelial wall will become more porous because you have an increase in membrane permeability. You'll also have more or less some sort of a distributive type of shock as a result of the vasodilatation. And if the vasodilatation is profound, this can eventually result in a drop in the BP and development of this distributive shock. So we also have global tissue hypoxia and organ dysfunction as a result of this endothelial disruption. And this leads to severe sepsis. With severe sepsis, you have multiple organ involvement, resulting in multiple organ dysfunction and refractory hypotension. And this eventually leads to septic shock. So, like has been mentioned, there are many schools of thought in terms of sepsis pathogenesis, but what is mainly believed is that there's an unbalanced immune reaction, which results in tissue factors and mediators of inflammation working together to produce a procoagulant state, microvascular thrombosis, and eventually there will be release of reactive oxygen species, which we know are potent inflammatory mediators. And you also have other unbalanced inflammatory effects such as profound vasodilatation and capillary leak. So the next form of shock is cardiogenic shock. So cardiogenic shock results from low cardiac output due to myocardial pump failure. So causes of cardiogenic shock include loss of contractility and also mechanical impairment of blood flow. So under loss of contractility, we have an acute myocardial infarction where you have impaired blood supply to the heart, and because of that impaired blood supply, the heart fails to effectively pump blood throughout the body, resulting in cardiogenic shock. We also have loss of critical mass of the left ventricle. We know the left ventricle is more or less the actual pump of the heart, and loss of this critical mass implies that there will be less energy or force with which the heart can contract and allow for circulation and facilitate for circulation. We also have right ventricular pump failure, left ventricular aneurysm, end stage cardiomyopathy, myocardial contusion, acute myocarditis, toxic global left ventricular dysfunction, and dysrhythmias and heart blocks. So here we're looking more or less at the ability of the heart to contract. Anything that can impede the heart's contractility or impair the heart's contractility, it can result in cardiogenic shock. We also have to look at the mechanical obstruction of blood flow. So you have valvular diseases, aortic dissection, ventricular septal wall rupture, massive pulmonary embolus, and pericardial tamponade. So the basic pathophysiology involves the drop in the cardiac output, resulting in compensatory mechanisms of the renin-aldosterone-angiotensin axis and release of antidiuretic hormone. This eventually results in adequate or an increase in blood volume. You also have catecholamine compensatory release, increasing the systemic vascular response. It also increases the preload, stroke volume, and heart rate. However, with these compensatory mechanisms, you find that there will be an increase in systemic and pulmonary edema, resulting in dyspnea. So that's where your dyspnea arises. And there's also increased myocardial oxygen requirements. And because of these increased myocardial oxygen requirements, we have a reduction in the cardiac output and a reduction in the ejection fraction, culminating in a drop in the BP and a drop in tissue perfusion, resulting in impaired cellular metabolism. So more or less, there's also a vicious cycle happening. With the impaired tissue perfusion, it causes reduced cardiac output and reduced ejection fraction, which further worsens the drop in the blood pressure, thereby exacerbating even more impaired tissue perfusion. Next is anaphylactic shock. So anaphylactic shock results from systemic vasodilatation and increased vascular permeability that is triggered by an immunoglobulin E-mediated hypersensitivity reaction. So anaphylactic shock, you have drugs such as penicillin and related antibiotics, aspirin, trimethoprim sulfamethoxazole, which is also known as Bactrin or Septrin, vancomycin, and non-steroidal anti-inflammatory drugs. Vancomycin causes a very famous syndrome in humans known as red man syndrome, and it's a form of hypersensitivity reaction to the drug. Other causes of anaphylactic shock include Hymenoptera stings, so we're talking about those stinging insects. We also have insect parts and molds, and we also have X-ray contrast media, ionic. Most commonly, we have methylene blue. We also have foods and additives, so there's shellfish, soybeans, nuts, wheat, milk, eggs, monosodium glutamate, nitrates, nitrites, and tartrazine dyes. So here we have antigen or the allergen, which is introduced into an organism, results in an immune response characterized by involvement of immunoglobulin E, thereby having a complement histamine, kinin, and prostaglandin release. And these are all they all elicit a profound anaphylactic-like reaction in the body. So we have an increase in capillary permeability. There's also an increase in peripheral vasodilatation, and there's also constriction of extravascular smooth muscle, such as bronchoconstriction, laryngospasms, and gastrointestinal cramps. So it's for this reason that you find that complement 3A and complement 3B are known as anaphylatoxins. Histamine, kinins, and prostaglandins as well have serious effects on the vasculature in increasing vascular permeability and also peripheral vasodilatation. So with these effects, you find that there will be a drop in the systemic vascular resistance. There will also be extravasation of intravascular fluids, resulting in edema and relative hypovolemia, thereby reducing the cardiac output and reducing tissue perfusion, eventually resulting in impaired cellular metabolism. Neurogenic shock. This is shock resulting from a loss of vascular tone associated with anesthesia or secondary to spinal cord injury. So this actually requires that the spinal cord is involved, and because of that involvement and that denervation, there's loss of vascular tone, which is able to maintain blood pressure, and this relative hypotension results in impaired tissue perfusion. So yeah, we have interruption in the CNS connection with the periphery. That's through the spine, through a spinal cord injury. It's a form of distributive shock as well. So it occurs after an acute spinal cord injury. So you have sympathetic outflow being disrupted, leaving unopposed vagal tone. This results in hypotension and bradycardia. Spinal shock is a temporary loss of spinal reflex activity below a total or near total spinal cord injury, and it's not the same as neurogenic shock, and the terms cannot be used interchangeably. So, whenever you're asked to differentiate spinal shock and neurogenic shock, you should realize that spinal shock is more or less a reflex type of shock that results from a spinal injury, whereas neurogenic shock is the actual shock that will arise, where we describe shock as an impaired tissue perfusion due to some circulatory collapse. So here we have the pathophysiology is such that there's an imbalance between sympathetic and parasympathetic stimulation, resulting in massive vasodilation, reduced vascular tone, reduced systemic vascular resistance, and this reduced systemic vascular resistance results in inadequate cardiac output. So the heart tries to compensate, but because of this increased vascular tone, the compensatory mechanisms are overpowered. So you have a reduction in tissue perfusion and impaired cellular metabolism. So what are the stages of shock? We have compensated shock. The body's compensatory mechanisms are able to maintain some degree of tissue perfusion. We also have decompensated shock. The body's compensatory mechanisms fail to maintain tissue perfusion and the blood pressure falls. We also have irreversible shock. So here you have tissue and cellular damage, which is so massive that the organism dies even if perfusion is restored. So this is where you find it is the last stage of shock, and when you have a patient reaching um, this stage of shock, there's nothing you can do to actually resolve the shock or resuscitate the patient. Thank you very much.